Good morning, everybody. My name is Ipazio Antonazzo from the University of Milano Bicocca, and here with me there is Dr. Carlotta Lunghi from the University of Bologna. Today we have the honor to introduce Professor Daniela Moga, who is an associate professor at the University of Kentucky. As you know, the goal of today's meeting is to talk about de-prescribing, so I suggest going ahead and straight right away with the first question. So, Professor Moga, for those who are not familiar with de-prescribing, could you please give us a short introduction on where de-prescribing comes from and how it is defined?
Sure. First of all, thank you so much for your kind invitations. I really appreciate being, part of this important meeting. To answer your question, I believe everyone is kind of, and the reason we are here, right? De-prescribing is an area of increasing interest for clinicians and researchers as well. And really the interest is to better understand how to and what are the effects of optimizing medications in general. And also in particular for those we consider high risk populations like older adults. And I would mention a very important paper in 2015. Dr. Reeve and collaborators, they published what we would consider a seminal paper, which was entitled "A Systematic Review of the Emerging Definition of De-prescribing with Network Analysis, Implications for Future Research and Clinical Practice." So this is the title of the paper they published, and they did a systematic review to really see what the term de-prescribing is about. And they mentioned that the term de-prescribing actually first appeared in the literature, in the English literature, in 2003 in an Australian hospital pharmacy journal with an article that discussed de-prescribing, achieving better health outcomes for older people through reducing medications. This article published in Australia outlined the principles of de-prescribing that include reviewing all medications that a patient is taking, identifying medications that should be stopped, replaced, or reduced, planning for de-prescribing with input from the patient, and also frequently reviewing and supporting the patient. So back to the paper by Dr. Reeve and collaborators, based on their network analysis, they came with the following definition for de-prescribing that is, I think, the most widely accepted definition today. And that is, de-prescribing is the process of withdrawal of an inappropriate medication supervised by a healthcare professional with the goal of managing polypharmacy and improving outcomes.
Thank you for the answer. And what are the main goals of de-prescribing and how may de-prescribing impact the healthcare system?
I would say that the overall goal of de-prescribing is to improve outcomes that are important for the patient. For some, de-prescribing might aim at reducing the overall medication burden or the risk of adverse drug events like falls or cognitive impairment, or improving global health outcomes in general. It might mean reducing hospitalizations or delaying death. Ultimately, I would say that all these goals are likely to relate to improving quality of life. And I would also say that in addition to these specific goals, de-prescribing can be framed as part of the good clinical practice. All medications have the potential to cause harm. They cost money, and they add complexity and the potential for burden, additional burden to the patient. In an editorial that was published recently in 2019, Dr. Farrell from Bruyere Research Institute and University of Ottawa argued that de-prescribing should be an essential part of good prescribing practices. She emphasized the importance of communication and collaboration with patients, family when appropriate, and other prescribers, which points to family physicians to play an important role in the process. I would say, as for the healthcare system, the team involved in de-prescribing needs to have time set aside for medication reviews and de-prescribing. And I will bring up the US healthcare system that I'm more familiar with, where reimbursement and billing codes are important as well. So there is an incentive for prescribers to also consider de-prescribing. It is important to see de-prescribing as a team effort that can use the expertise and services of, let's say, pharmacists, nurses, other healthcare professionals, either to lead the process or to complete, time-intensive tests, or be part of a multidisciplinary team that will get involved with the prescribing. And in the US, for instance, there are such programs like Medicare Part D medication therapy management, which I'm more familiar with. And I know there are similar programs, for instance, in Australia. I believe their program is called Home Medicine Reviews. And so there are these systems that could be seen as a way for engagement of healthcare teams into the prescribing. An important consideration with regard to the impact on healthcare system is the fact that de-prescribing needs time. It's not a very quick process if it's done, safely. And the process should continue over several visits with the patient, and it should not be a once and done. It should be, longitudinal, right? For as long as the patient is engaged in care, de-prescribing as well as prescribing should be both considered. And another important point with regard to de-prescribing and impact on healthcare system is the engagement from the patient and the education of the patient, so they see de-prescribing as part of the whole process, as opposed to withdrawing care to them just because somebody decides that they should not be taking certain medications anymore. So education of the patient is also an important component that should be considered.
Thank you.
Okay, thank you for your responses. I was wondering that to date, especially older people are prescribed often many medications. So we talk about polypharmacy. And in your opinion, which is the best criteria to decide on discontinuing medication, especially for the elderly, and which tools are available in practice to implement the prescribing?
Sure, I think this is a really important, consideration, and I don't think there is like a one size fits all approach. I think there are a few principles that are now widely accepted with regard to implementation of the prescribing. And one of them is something I mentioned a little earlier, is that the prescribing should be seen as an integral part of prescribing process, which as a result means that medications should be reviewed and monitored on a regular basis. I would even argue that maybe we should get into the habit of monitoring medications the same way we do maybe with blood pressure control, right? Whenever you go and see your physicians, you have your blood pressure measured. So I think a similar mindset would be beneficial when it comes to the prescribing and medication optimization. I would also argue that an important guiding principle with regard to the prescribing is engagement from the patient. Patient should be well aware of the medications they are taking. They should be given the opportunity to learn about their medications. And I think it's even more important in today's world with so much information at our fingertips and sometimes misguiding information that is available wide on the internet. So engagement between patients and their healthcare professionals should be an important component, and the prescribing should be a topic of the conversation. Now, I would say that whenever a new medication is prescribed, there should be an understanding that de-prescribing might be an option later, right? So we should not consider a chronic medication that once it's prescribed, it will be staying on their medication list forever. I think these conversations are very important to be carried out early in the process, so then the patient doesn't feel let down when the prescribing is brought into consideration. I would say that a rigorous assessment of risks and benefits, as well as patient goals, which might, change over time, would be a well accepted strategy for the prescribing. And with regard to tools that can, help with implementing the prescribing, there are several in use, and depending on the country, some might be preferred over others just because they are more adapted to what is available in that country. And I would, mention the Beers criteria, which is overseen by the American Geriatric Society and includes a list of medications that should be considered potentially inappropriate, right? So they could be used to flag certain medications and open a conversation about the prescribing. But there are other criteria like the STOP criteria that are used worldwide. Again, creating a list of potentially inappropriate medications that should be considered in terms of risk-benefit profile for the individual patient. Other tools are more about appropriateness of prescribing. So, for example, the Medication Appropriateness Index is helping clinicians to incorporate information about the patient and their situation, including cost of the medication, risks and benefits, into creating a profile for each medication and assess whether the risk benefit is still favoring the benefits and it's keeping the risks under control for the individual patient. So this could be a few examples of tools that are widely available and have been, evaluated over time that could help one into considering the prescribing.
Yes, and do you think that there are some certain patient groups, we talk about elderly in general, but there are specific groups or maybe perhaps area of medicine that might benefit more from the prescribing than others? And are there estimates on a proportion of patients who could benefit from the prescribing? How many are there?
I think this really depends on how we look at the prescribing and what the goal of the prescribing is. And I think a lot of the prescribing initiatives are focused around polypharmacy and high-risk populations. And, when you think about who is at high risk, you already mentioned older adults. Age by itself is not necessarily a risk factor. However, advanced age is often a time when, there are more and more health-related problems. So we are, seeing patients with multiple chronic conditions, seeing multiple healthcare professionals. So that's this increasing the risk for multiple medications to be prescribed, polypharmacy, drug-drug or drug-disease interactions. They could also transition care from maybe hospital to long-term care or even home, where there are opportunities for miscommunication, which increases the risk. In addition, changes in pharmacokinetics and pharmacodynamics are also things that come with age and that can increase the risk for drug-drug or drug-disease interaction. Aside from older age, I would say, and you mentioned also polypharmacy, and there is, strong evidence to suggest that the use of multiple medications, which we define polypharmacy based on, is the strongest risk factor for medication-related problems. And while there isn't a specific threshold, the threshold might depend on the individual patient. I think it is well established that the use of 5 or more medications is really a useful benchmark to categorize somebody as having, being at high risk for medication-related problems. Now, quantifying the prevalence of polypharmacy and how many patients would benefit from de-prescribing is also like the estimates vary widely. I've seen, depending on the population, I've seen estimates that are up to 90% of a certain age group. But I would say a significant number of patients, maybe, it's 40%, maybe it's 50%, are at increased risk and would, suffer from polypharmacy. Now, this wide range depends on how the definition is used. So we could talk at length about all of these issues, but is it just prescription medications? Is it prescription and over-the-counter? Those are things that really impact the way we evaluate the prevalence of polypharmacy. Regardless, I think all point to the importance of this as a big problem in our society today, and the fact that de-prescribing could really have a beneficial impact both on clinical outcomes as well as on economic outcomes, both from the patient and the society perspective. And back to your question with regard to risk, I think you mentioned older adults in general, but within this group, those with multiple chronic conditions, those that have impaired renal function, those are factors that would really increase the risk even further. Limited life expectancy. There is conversation about de-prescribing in those that have limited life expectancy and whether they should still continue with maybe preventative medications. And there are studies to show that the risk-benefit balance is definitely not favoring the continuation of some of the preventative medications, while some other medications that might be flagged as inappropriate in younger populations, for example, opioids, those might be, or anticholinergics, those might be actually something that will improve quality of life in patients with limited life expectancy. So again, this risk-benefit balance really is important to account for the unique patient characteristics when discussing. So I would argue that when thinking about risk and medications to target, it really should be aligned with the patient and the patient characteristics and their goals for the remaining of their life. Frailty and dementia, I could also argue that are, populations that could be at risk for the inappropriate medication use, and where de-prescribing might have an even a bigger impact, right, than in younger, healthier populations. So that's kind of like in trying to keep things under a certain time limit, a few things to consider with regard to who might benefit from de-prescribing.
Yes, thank you. We are talking about the patient, but I am a pharmacist by training, so I'm a pharmacoepidemiologist, but pharmacist by training. So I was wondering, what is the role of pharmacists in the prescribing?
The evidence is there. There is strong, the evidence is very strong in supporting the active engagement of pharmacists in de-prescribing. And from my personal experience with de-prescribing, pharmacists are, part of like an important part of our team approach to de-prescribing. I would say in certain situations, pharmacists can take a leading role. In others, they should, be part of a more multidisciplinary collaborative team with other healthcare professionals. And really, this might depend on the healthcare setting and whether the pharmacist is integrated in the provision of care in that particular healthcare setting. Involving pharmacists might also be challenging at times, but again, these are things that are well established, and maybe it's time for us to think how to better engage with pharmacists in the prescribing. And one of the important issues is that when a non-prescribing clinician, like pharmacists, are making recommendations for the prescribing to a specialist or a primary care clinician, it is so communication is really important. Having clear information on why the medication should be de-prescribed with supporting evidence when possible, as well as to how to conduct the prescribing, and again, establishing a channel of communication with those other healthcare professionals is very important. And I would like to mention that, there are templates available for communication of the prescribing recommendations between pharmacists and clinicians. And there have been trials to show how this can further support the prescribing initiatives. The Canadian De-prescribing Network has done tremendous work in this area, and they actually have all of these tools and templates made available to professionals to use. I would say from our experience and in working with pharmacists that are not integrated in clinical settings, the challenges and difficulties is with having sufficient information to make those recommendations be sound and accepted by other clinicians when they rely on very limited healthcare information and might not even have access, for instance, to lab results and other essential information to making a judgment on risk and benefits.
Yes, absolutely. And let's talk about attitude towards the prescribing. So what is the attitude of different stakeholders like patients, caregivers, family physicians, specialists about this de-prescribing?
Yeah, so I will mention Dr. Reeve again. She's conducted quite a bit of work in this area as well, and actually they developed and refined an instrument that has been widely used into assessing attitudes towards de-prescribing in patients. So the revised patient attitudes towards de-prescribing instrument has been translated in several languages, and I believe it is available in Italian as well, and has been used to survey groups of patients with regard to how they perceive de-prescribing. And regardless of the country or the setting, even though patients might not be familiar with de-prescribing in general, all the studies shown that approximately 90% of the older adults that had been surveyed, and including some, for some studies, caregivers of older patients, said that they would be willing to stop one or more of their medications if their doctor said it was possible. And other important, findings from these studies was that when patients are provided with educational material so they can learn about the process of de-prescribing, they are even more willing to consider such a path if their physician considered that would be something that they could do and do safely. right? So patients are open. Now, on the other hand, their medical culture in general has been something that was pointed as a barrier to de-prescribing. Throughout the history that we've been going through what would be called a clinician-centric culture, where prescribing is part of a professional identity. A lot of clinicians and even patients might see prescribing a medication as a positive action. I'm doing something to help you. Whereas de-prescribing might be seen as a lower priority and might be seen as actually a negative action, right? I'm withdrawing care from you. And so even the perception, it's something that, maybe we need to undergo a culture shift and see de-prescribing under different lenses. The other important thing to consider is the fact that when medications are prescribed or recommended by another clinician, such as a specialist, primary care clinicians that are the ones that might deal with the patients on a more regular basis might feel like it's not their role to stop a medication that the specialist recommended. They might not make the changes because they feel there is professional hierarchy and they do not want to overstep their role. They might be concerned about damaging their relationships with the patient. So I think to address all of these, a culture shift and better communication, so there is really, channels of communication open between the patient and all of those involved in their care would be something to consider. Now, I'm not saying it's easy, but this is something that all research points towards being an important component of successful de-prescribing.
Thank you, Professor. So we talk about the role of different stakeholders in de-prescribing. Now, I would like to go deeper on the role of epidemiology in promoting de-prescribing. So from your point of view, which are the main issues that epidemiologists in general and pharmacoepidemiologists in particular should address?
This is a great question, and actually, the pharmacoepidemiologist in me wants to really, showcase how we can contribute to this area of inquiry. And just to kind of provide a little bit of background, and I know most of the attendees are epidemiologists or pharmacoepidemiologists, but as with other areas of pharmacoepidemiologic research, observational studies of de-prescribing would likely rely on the use of electronic health records or healthcare claims data. So, most of us would think of pharmacoepidemiology as using existing data that obviously has, advantages and some disadvantages. And like with any other area in de-prescribing research, the same advantages and disadvantages might play a role. The important point to make is, these data that we would consider typically for pharmacoepidemiology are not collected for research purposes, and as de-prescribing is not a randomized, treatment, and therefore, if you are not careful in using these data, results of our research studies might be subject to bias. An important issue to consider is, for example, the exposure definition for de-prescribing using real-world data. These definitions can be susceptible to misclassification, as sometimes medication cessation might be due to non-adherence from the patient or temporary holds on medications rather than the intent of stopping, what we would consider de-prescribing. In addition, comparisons of patients discontinuing versus continuing medications might be subject to confounding by indication or disease severity. And so despite a clear need for observational studies of the prescribing effects and awareness of numerous biases that can affect pharmacoepidemiologic examination of stopping medications, unfortunately at this point there is very little guidance to set best practices for the design of the prescribing studies and optimal methods for estimating causal effects, often the prescribing on specific healthcare outcomes. So these are all issues that I raised. However, this is also bringing opportunities for how epidemiology and pharmacoepidemiologists can contribute to further our understanding of the prescribing in general and the outcomes associated with the prescribing. We need pharmacoepidemiologists to develop strategies, for instance, on how to best measure key research variables while minimizing misclassification. We need to set best practices in designing observational studies of the prescribing that will address this potential for bias that could arise, right? So not just the general pharmacoepidemiologic approaches, but applied to the prescribing research. And something that might not be totally, possible to be addressed by pharmacoepidemiologists. I think we need to find opportunities for enhancing the existing data sources that we would consider in traditional pharmacoepidemiologic research, so we can truly use them and learn from the patient experience into the prescribing using existing data. So we can truly look at a population approach into evaluating the prescribing. Last but not least, and definitely very important, is to make sure that, back to your question about stakeholders, those that are in charge of setting priorities for funding can also see, right? So policymakers can also see the importance and the potential impact of the prescribing. So then they are, I guess, prone to seeing this as something that needs to have available funding for good research into the prescribing.
Thank you. And do you think that observational studies can contribute to providing evidence, identifying tools and practice, and evaluating the impact of the prescribing?
So the short answer, and after all the things I said, I would say yes, I believe so. However, certain things need to also happen. And I would point out to the fact that one key barrier to the prescribing is the lack of evidence on the effects of withdrawing medications in generalizable populations, thus making it difficult for clinicians to determine the risks and benefits in practice, right? So the clinicians might not be invested in doing this type of interventions with their own patients just because we don't really know that much on the long-term health-related effects of the prescribing. And while I think it's widely acceptable that randomized controlled trials are the gold standard for clinical research, and they can be used to establish evidence for interventions, including the prescribing, they have numerous challenges, especially the ones dealing with the prescribing. They have challenges with recruiting older adult participants. They have difficulties with measuring effects on long term, right? Because those will require long-term follow-up. So they often fail to really measure clinically relevant outcomes and stop at measuring impact on number of medications, right? Which could be important, but is not the ultimate goal. And then it also is important, and the randomized trials have challenges with comparing the impact of the discontinuing therapies at different points in a patient's clinical course. So to give you an example, there was a randomized study of statin discontinuations in older adults, and they show that nearly 40% of older adults that were eligible, would have been eligible for the study, were not included due to barriers to enrollment, and that included, physician and patient unwillingness to get engaged in those. So as a result, randomized trials are often underpowered and lack sufficient follow-up to detect differences in clinical outcomes and really inform, practices and decisions with regard to the prescribing. So one can argue that, oftentimes we rely on systematic reviews and meta-analyses to combine the results from smaller trials. However, there are limited studies that could be incorporated in such an approach with regard to the prescribing, either because each trial might be looking at, targeting a certain type of medication for the prescribing. So there is quite a bit of heterogeneity in how these randomized trials are conducted, therefore making it difficult to generalize their findings. So all of these point to, areas where observational research could, bring important evidence to kind of complement what we learn from clinical trials. I'm not arguing that we should go one way or another. I think we really need to consider various approaches into studying the prescribing so we can have a more complete picture of its effects in the population.
Thank you. So you talk about healthcare administrative database and also randomized control trial, but based on your experience, which data sources are the most appropriate for conducting research on the prescribing?
So I don't think there is a perfect data source. Right, we talk about the importance of considering real-world data, and we already discussed a little bit about the use of electronic health records or healthcare claims data. They can be, a great way to uniquely address gaps in knowledge on the effect of discontinuation in timely manners. I think these studies can leverage existing healthcare data to study the prescribing in a more representative population with longer follow-up and evaluate clinical outcomes. What these data lack is really that patient input. So I think if, in the future, these electronic health records will do a better job at really capturing more on the patient side, gathering information on patient preference. I think that could, and goals with regard to prescribing and de-prescribing with health, care in general. I think this will really enhance existing data and will allow us to get a better picture of the effect of stopping or reducing dose or replacing medications to maintain a safe risk-benefit profile.
Thank you.
Thank you. We have talked about research. Now I would come back to clinical practice. And could you give some examples of successful implementation of the prescribing in clinical practice?
Sure. I think the key here is, the word success, and what do we consider to be success? Is it, do we define success in a matter of stopping a medication that was recommended for the prescribing? Or is it something that, we de-prescribe having a clinical outcome in mind and whether we succeeded for that patient to reach the desired clinical outcome? So I think in terms of stories of success from what we've seen in the literature, I think that there is quite a bit of evidence to support the impact of de-prescribing in reducing polypharmacy and reducing the number of potentially inappropriate medication use. I mentioned we've been involved in a few randomized trials that used a multidisciplinary team approach into de-prescribing, and that involved the prescribing clinician, it involved a pharmacist, and it actively involved the patient. And in terms of success, we were able to implement in an Alzheimer's disease clinic a successful intervention to reduce the number of anticholinergic medications within the follow-up of that study. Once we stopped the intervention, it actually, we were able to track those participants and show that a lot of them started using anticholinergics again. So that to us was a lesson learned into and kind of showing that if you want to be successful in implementing something, it cannot be a one-time intervention. It has to be sustained, and the engagement should continue, over the years with any, opportunity for prescribing or, encounter with the patient. But I would also like to mention that, I briefly mentioned it earlier, the discontinuation of statins, the trial. They actually show that, in patients with less than 12 months to live, discontinuing statins was successful and did not alter their time to death compared to those that continued on statins. So, however, those that stopped statin reported better quality of life over the duration, right, of their life. Now, with regard to larger implementation in clinical practice, and since this is a conference of interest for Italian pharmacists and maybe pharmacoepidemiologists, I know that there was a fairly recent physician-focused multi-model quality improvement initiative that took place in, I think it's called the Local Health Authority of Parma, where they were targeting the reduction of potentially inappropriate medications exposure in older adults. And I think the initiative involved the development of an Italian-focused potentially inappropriate medication list. So speaking about, making sure you are in line with what is available and in use in the country. They also provided educational materials and dissemination of that particular list of medications to general practitioners in the area. And they provided feedback to these GPs on their performance with regard to prescribing and stopping these potentially inappropriate medications in their patient populations. And I think they showed that the intervention itself, right, so it was providing a list of medications that could be targeted, educating them on what can be done. They showed a decrease in potentially inappropriate medication use and also a decline in unplanned hospitalizations. So I would call this a pretty successful an example of a successful intervention that is using general practitioners in an area. In the US, a recent study that I'm aware of, and I'm following to learn more from their results, is one that's called the OPTIMIZE trial, which stands for Optimal Medication Management in Alzheimer's Disease and Dementia. This is a pragmatic, primary care-based cluster randomized trial that involves older adults with Alzheimer's disease and related dementias, as well as their caregivers. So they target these patients that have Alzheimer's disease or other dementias, and they also suffer from multiple chronic conditions and have polypharmacy as defined as 5 or more medications. And they use the Kaiser Permanente, Colorado, all of the prescribers and patients that are seen in this healthcare system, and they are also provided with informational materials and tips about de-prescribing. So I really like this idea, and I'm hoping this will become a successful story, because being a pragmatic trial, similar to that example from Italy, it involves very little intervention that a lot of the more traditional randomized trial are so standardized and then less generalizable, because they don't provide opportunities for deviating based on either provider or patient characteristics. So again, this is a pragmatic intervention. It's designed to be relatively simple, be really generalizable. So it kind of is, I would see it as a bridge between the typical randomized trials and the observational ones. So they are really engaged in the routine clinical practice. And they involve, education on the patient and caregiver side, as well as on the prescriber side. So hopefully, we will learn more about what could make something like this successful for a model of a larger implementation of the prescribing within different healthcare settings.
Thank you for this example, for these successful examples. So, to conclude this chat, what are the lessons learned from these examples in terms of opportunities and obstacles?
I think I touched on several, barriers, obstacles to the prescribing, and I think key is to really consider a wide range of approaches to study the prescribing and its effects. I think we need to consider the more traditional randomized trials, as well as the more pragmatic ones that allow for larger populations to be enrolled. We need to consider observational studies, and we also need to consider, various implementation strategies to make sure that, successful interventions can be disseminated in larger populations and in a variety of healthcare settings. We know that, RCTs of the prescribing have numerous challenges, and I mentioned quite a few earlier. And we also know that observational studies are confronted with, the risk of misclassification or bias. And we also know that while certain strategies can work, a large-scale implementation has unique challenges, including specific features of the healthcare system, the ability to truly engage with the patient and their caregivers where appropriate, as well as to engaging multidisciplinary teams to coordinate care in a continuum. And I see all of these challenges as opportunities for us to engage in research that could be quite impactful. And again, I think the funding environment needs to also be set in such a way that will encourage this type of research. I would say from lesson learned, I think the themes, aside from, a wider range of research that's still needed, I think considering engagement as a multi-team approach with active engagement from the patient is probably the way to go. It might be more time consuming, but I think if we are thinking in terms of success stories, I think the investment is necessary to be able to see the benefits.
So thank you very much. We are concluding our interview. We would have many more questions, but time flies. Thank you again, Professor Moga, for this insightful discussion about de-prescribing, its challenges and future perspective. Hopefully everyone enjoyed this interview, which was conducted as a part of the intersocietal activities of the Italian Association of Epidemiology and the Italian Society of Pharmacology. And I would also like to thank the other members of the scientific committee, beside Ipazio and me, Ursula Kirchmeier and Eliana Ferroni from the Italian Association of Epidemiology, and Gianluca Trifiro, Elisabetta Poluzzi, Manuela Casula, and Salvatore Crisafulli from the Italian Society of Pharmacology.
Thank you so much for the invitation. It's been a pleasure talking to you.
Thank you.